I'm an addiction medicine specialist with Alberta Health Services Virtual Opioid Dependency Program. I saw a few years ago that people were struggling to connect with the care that they needed and deserved in the middle of an opioid epidemic. It really wasn't good enough. I'm pleased to say that we found some solutions that are really helping people every day in Alberta.
All right, what's up, everybody? That was tonight's guest, Nathaniel Day. I'm Daniel Unmanageable, and this is Hard Knox Talks, coming at you from Saskatoon, Saskatchewan, Treaty Number 6 territory and the traditional homeland of the Métis people. Let's bring in Nathaniel. Hello.
Hey.
How are you?
Hi, good evening. How's it? I'm good, thanks.
Good. Things are going well. Everything is running. Nothing's on fire. This is fine.
Yep.
Is there?
Are you guys as cold as we are in Alberta? It's like minus 32 here right now.
My toes are cold right now. Actually, it's minus 33 here right now. We have you beat.
There you go.
So, anyways, is there anything that you'd like to say tonight before we jump into the grill session?
Well, I just am really honored to be here and really look forward to chatting with you and with Donna, and as well, with the guests who chime in. I'm really hoping that I can answer hard questions and share some of my perspective.
All right. Well, without further ado, let's jump in.
This is Hard Knox Talks.
All right. Well, before we officially jump in, I'd just like to let our viewers and listeners know that tonight's live production is premier sponsored by Prairie Sky Recovery Center. Prairie Sky Recovery Center offers intensive inpatient addictions treatment in Leipzig, Saskatchewan. So, tell us a little about the experiences you've had that led you to wanting to find a safer way for people who use substances.
Yeah, well, I've had a little bit of a journey. So I, completed my medical training. I was a family doc in my original training, and came out to rural Alberta to work. And there's an addiction treatment program for people with severe addiction, severe mental illness in Ponoka. And when I came here, none of the other docs wanted that job. So that was one of the things I was assigned to. And so I quickly realized that I didn't really know anything about addiction and that I needed to know more. So I started working on my addiction certification. And so I'm a certified addiction medicine specialist. And, I saw pretty quickly that there were some serious problems with the system, that the system was designed for the system, not for the people who needed it. And so, for example, back when I was working in inpatient rehab, for example, you'd have people who come in with opioid addiction, and the evidence is to provide them with methadone, suboxone, but we had nowhere to send a person. So if they were started on treatment, and then they left treatment, there was no one who would pick up their suboxone treatment, for example, or their methadone treatment. And so we, the medical director at that time was saying, no, we can't start people. And so, we're seeing people die of overdoses when they'd leave rehab. It was just awful. And then, on top of that, other challenges. So I, for a time, worked in brain injury rehab, and, seeing people with anoxic brain injuries from overdose. And, you sit there and realize this person's going to need
hang on now, hang, you can't use big words like that. And
sorry.
Be like, I'm going to call you on it. What is an anoxic brain injury? Just briefly,
Anoxic just means no oxygen. So I stopped breathing from my overdose, and it resulted in part of my brain dying.
Oh, man.
And so I have severe disability from that, but I survived.
Mm-hmm.
And so we have, people with anoxic brain injuries who are going to require lifelong care. Mm-hmm. And I was sitting there going, oh my goodness, just the care for a few of these people would pay for, wide access to treatment.
So you felt like why are we allowing this? Like, why are we allowing this to happen?
Exactly.
Yeah,
exactly. And then one of the sort of major sentinel moments for me in my practice, as I was thinking about this stuff, was that I was working at our psychiatric hospital, and I was on call for psychiatry, and I had this young lady come in through the doors, and in her situation, she discovered she was pregnant. She was living in one of the big cities in Alberta, and was using fentanyl. And so she went to a local program, was started on methadone, did really great, was able to stabilize, and was healthy enough to take baby home with her after delivery. And she went home, discovered that being a young mom in early recovery was tough. And so she made a pretty responsible, reasonable decision for, anybody, which was to move home to be closer to her family and get support. But what happened in her case, and how the system was set up back then in Alberta, was that she moved to rural Alberta, and her methadone provider in the city cut her off methadone because she couldn't come to their pharmacy, and she couldn't come for her doctor's visits in person. And so she went through horrible withdrawal, as we can all imagine, and then she relapsed. And when she relapsed, Children's Services was monitoring, saw the relapse, apprehended baby. And so the reason why I was doing this consult in the middle of the night in this building, actually, where I'm sitting right now in my office, was a suicide. She had attempted suicide and survived the suicide attempt. And we were doing her intake for that. And I was sitting there across the table, and my heart was breaking, because really she had done so many amazing things and stabilized so well and was motivated by all the right things, and the system just wasn't designed to help her. And the system totally failed her, and she was there because of a system problem, not because of a her problem.
Yeah.
In my opinion.
So was there a time?
It was for.
Hang on a sec. Sorry to interrupt you.
Yeah.
Was there a time?
No,
was there a time where you thought that the old punitive means of treating substance use challenges was effective? Like, did this open your eyes to a new way of thinking, or did you always sort of have this compassion?
Honestly, I've always been skeptical of some of those traditions of care that don't have evidence behind them. On it, like we were talking about this the other day, but even that idea of, you have meth in your urine, so I'm going to cut you off of your suboxone or your methadone. And it's if we were thinking about this from a heart disease point of view, that's like saying, okay, you've got diabetes, I'm going to cut you off of your insulin because your cholesterol is high and you're not doing enough about your cholesterol. It's just insane. And so anyway, it doesn't take very long working with people where you're making connections and you care about them and you want them to do as well as, and do well in their life and what their goals are, for you to say, hey, look, this punitive stuff, A, doesn't work, and B is like, it just, I don't know why it's there,
Yeah. So did you find yourself like advocating to your peers on behalf of some of these patients that you were seeing, or other people were seeing?
Sure. Yeah. Well, I mean, when I was back in inpatient, I used to have arguments with my colleagues. I was a very junior, very brand new doc, but basically saying, look, so for example, not starting someone on methadone who's dying of, of withdrawal, and they're just suffering, and we know the outcome's bad by detoxing them. And we're not offering them evidence-based care, and the excuse of saying, well, we've no one to send them to, it's like, well, then let's figure it out, right? Like
why not?
Surely we can do something about that, but fortunately in Alberta it's not that way anymore.
So when we're talking about the virtual opioid dependency program, I hope I got that right. I think I did.
Yep.
Tell us some of the barriers that you saw when you were developing that program. Like, what were some of the things that did it ever feel like you were banging your head against the wall trying to, develop policy that was effective or anything like that?
Honestly, we've had such an amazing run. So we were started about 6 years ago, and what we did, so after that, serious suicide attempt case and those other cases, I wrote a proposal saying, look, let's try a virtual approach. So there are other people who are doing virtual care in North America, but it's always in conjunction with, stabilization in person, and then the very stablest people get some virtual care. I said, look, that we need to use technology to reach people, just like your podcast is reaching people all over the place. We let's actually reach out and see if this works. And so we got a small grant and had a little team, and we started to do some of this work, but and it was amazing. It was truly amazing to be able to reach people who had never had access to care before. But then, like you were saying, there were challenges too. So, for example, it used to be for us that, if you wanted care, you'd phone in or you'd get referred or whatever. And our team would reach out to you, and we'd book a telehealth at a local telehealth site. And that might take 3 or 4 days to get the confirmation and get you in. And then we get you started then. And so there was a case where there was a young woman who her addiction counselor had referred her and had called us. And when you get that paper referral and phone call, they're really worried about the person, and so they were really worried about her overdose risk. And so we called her, and we reached out that same day, and we did a bunch of things, and we never reached her. And we found out a few weeks later that part of why we never reached her was that she was already dead. And and it, yeah, and so we were sitting there. I mean, our team, we have this really awesome team that really care and are really working hard, and it was devastating. And so we took that and we dug into it, instead of saying, oh, well, we did the best we could and she didn't pick up her phone. It was like, the system has to change to meet people where they're at.
Like her not picking up her phone, like her not picking up her phone is quite possibly a symptom of the disorder she's trying to seek help for. And quite
exactly.
often that is what happens, is that when we display these either drug seeking or whatever toxic behaviors, oftentimes they are a result of something deeper, right? But we're judged at surface level instead of seeing them as symptomatic. Is that accurate?
Yeah, for sure. Yeah, for sure. And in fact, there are things that we can do, that we traditionally do, that we can do better, that actually will make our jobs easier too. So, with that case, we looked at it and we realized she died before we could have ever got her into telehealth. And we realized that, telehealth was a barrier. So as much as it was a enabler for us to get into lots of communities, and we serve every single community in Alberta, the fact of the matter is that, some people need care right now, this minute. And so we worked with Alberta Health Services and with the College of Physicians and Surgeons, because we have to follow the rules and we have to, do things that, within the regulations. None of us want to lose our licenses and things like that. But we worked with them and we developed, a strategy for doing same-day medication starts. And so in Alberta today, a person can call a toll-free number anywhere in Alberta, from any little hamlet to town to village to city, and they can speak with a professional and start an intake and speak with a prescriber and get started on OAT the same day that they call, right away. And so in the case of that young woman who passed, the fact of the matter is today we'd do better. And I wish she were here. I wish we'd have done better for her. But we learned from that. And so today, her addiction counselor, when she's there in the office, baby could just pick up the phone and immediately connect her with help. And before she's even walking out of the office of that addiction counselor, she's got a prescription at the pharmacy most convenient to her so that she can get going.
Donna's got something to say.
Just a question, Nathaniel. How long was this process? Like, the way that you describe it, sounds like it happened relatively quickly. So aside from like how long did it take, how easily would it be replicated in other provinces?
Yeah, well, and I know that there are other provinces that are interested in what we've been doing. So we've had information sessions and stuff for provinces east and west of us. And the reality is that this, if you have the right staff and the motivation, this is something that can be done pretty quickly. once we've done a lot of groundbreaking work, and we're happy to share it. So
Mhm.
for example, if there was a group in Saskatchewan that was able to get funding and have some staff in place to actually do this kind of work, we would share everything we have in terms of processes and policies and workflows and checklists and things like that to help it go. And we have, and we would have people even come out with us, and we could show them how we do it and train them. Because at the end of the day, I'm so fortunate in our province with the work that our team has done. We've been able to go from a place where people had very restricted access to OAT, opioid agonist therapy, and today everybody has access, and same day access. And the gratification that I feel for that from the hard work that's been done is huge. And I mean, I can only imagine how happy I'd feel if our team and the processes we have and improvements in other places could ensure that all Canadians and eventually all Americans and everybody in the world who wants care and needs care can get the care that they need right when they need it.
It's a pretty big statement, man. Yeah. So this all sounds very, how do I want to say this? I'll just like, what does harm reduction mean to you in all of this?
That I love that question. I think that there's sometimes this weird view that harm reduction and treatment are opposite sides, and they shall never meet.
Mhm.
When the reality is that harm reduction is something that should be part of our practice, in treatment all the time. And I know that in harm reduction, when I go and visit supervised consumption sites or overdose prevention sites in Alberta, when I talk to the staff there, um, they talk about how hard it's been in the past. When they've got someone who's really sick and really wanting help today, that in the past it's been almost impossible to get that person in for help today. And so we really need to sort of bridge that divide and keep working towards where a person who's at an overdose prevention site who's saying I'm tired of the grind can get help from treatment today, and a person who's in treatment and and struggling and continuing to use can have harm reduction sort of practices applied to their treatment so that they continue with treatment and they're safer than they would otherwise be. So for example, we have in VODP a low barrier urgent access team that started out as a sort of a little side project because we realized that there were these sons and daughters, brothers and sisters, mothers and fathers
Mhm.
who were really struggling to jump through the hoops of ODP. And so, you'd have a person where we'd do a same day start for them, and then we'd do the work to transition them to a face-to-face bricks and mortar program in the city. And then that program, would discharge them because they didn't show up for an appointment. And then they'd call us back, and we'd sit there and say, this person struggles with homelessness. This person doesn't have any idea what time of day it is, on most days of the week, to be frank.
Mhm.
And setting them up for failure by saying next Tuesday at 2 o'clock, you've got an appointment. And if you're not there on time, you're a no-show, and we're going to end your
And you're,
life-saving medication.
yeah, you're
It's
out in
just,
the
it's
sticks
just
again.
completely, yeah, it's completely preposterous. So we set up our low barrier team to say, hey, look, for people who are struggling to navigate the stupid part of our system, um, we want those people to get the evidence-based care and to have no barriers
Mhm.
or as few barriers as possible. So for example, in our low barrier team, instead of saying, hey, John, you've got an appointment next Tuesday at 2 o'clock, we say, hey, John, we'd love to hear from you sometime next week. And anytime John checks in next week is the
Is a
right
win.
time for John. And we'll connect with him. We'll just make time for him right then and there.
Mhm.
And then in similar ways saying, hey, John, you've been on methadone, 5 times, and you've really struggled with suboxone. What about this Sublocade thing? And we've seen some really, really good results there where people who've otherwise really struggled and had continued use have gone on Sublocade, and they've, found that they're using less and less over time, and they don't feel sick the next day, and then they just stabilize out. And next thing you know, and I can think of one of my patients, she's just amazing story, where that worked for her. And so she went from using, on suboxone 5 times a day to going on Sublocade. Then it was 5 times a week, and then it was a couple of times a week, and then once a month. And she's just really gradually had the life that she wants, because she wants out of the grind.
Mm-hmm.
And so much so that, she no longer wants to be in her low barrier harm reduction housing, because she doesn't want to be around people who are using. So she's moving into regular housing. For the first time in several years, she actually has access to see her kids for Christmas, and some things like that, where you say, hey, harm reduction isn't meeting a person where they're at and leaving them there. It's meeting them where they're at and using every opportunity we have to help them so that they can achieve the goals that they have. And I'm biased because of the people that I see and the people who come to me for help. But so there are a whole bunch of people out there who don't come to me for help. But for the people that are coming to us, no matter what degree of struggle they're working with, the fact remains that they're coming for help because they're not happy with the situation they're in.
Yeah. So we were talking just before the show, and you started telling me about levels of prevention in public health strategies. So what does that mean, and where do these levels fit into the spectrum of care when it comes to mitigating harms from substance use?
Yeah, for sure. So in public health, there's a sort of pyramid of work, right? So there's something called primary prevention, which is the bottom level of the pyramid. It's sort of the cheaper interventions to do that cause great, improvements in health. And then there's secondary prevention for people who are already having challenges, and tertiary prevention, which is the third tier and the sort of the smallest tier ideally. And the idea is basically that you want to, the primary prevention, the bottom level, is really intended to help people avoid having harm in the first place. So for example, if we were talking about smoking cessation or smoking, we'd say, look, an education campaign with youths, awareness of the risks of smoking and so on, might make 5% of those youths not smoke ever. And that prevents a whole bunch of harm for them. Then you go to the secondary prevention. You say, okay, well, some youths are smoking already or are going to smoke no matter what we say. And so what do we do to help those kids, be safer? So, we put filters in cigarettes, and we make it harder to access tobacco, as you have to be 18 in order to buy it. And, we make it so that the labels are behind the shop. Well, I'm ad-libbing here. So anyway, you've got this secondary prevention, which is aiming really to help people who haven't had long-term harms from smoking, but are smoking already. And then tertiary prevention is, you've got someone who's got significant harms from smoking. So let's say they've got emphysema, COPD already. And even if we stop the smoking, they're still going to have damage in their lungs. So now we're into a much more intensive, much more expensive for the individual kind of treatment, treating their lung cancer, treating the stroke that they had because of their smoking. And so, in terms of overall substance use and opioid use, for example, we need to be really careful that whatever interventions we're doing to help our most affected community members at that tertiary level, and we need to help them. It's not to say that we don't have interventions for tertiary prevention. We do. But whatever we do at that tertiary level, we have to make sure that it doesn't undermine the primary prevention and the secondary prevention. Because, if we undermine primary and secondary prevention, we're just going to continue to have waves and waves of people who, if we're talking about smoking, we're going to have more and more people smoking, more and more emphysema, lung cancer, and strokes. And we don't want that. So we want to make sure that whatever we do, we're supporting those primary interventions. So for example, using smoking as an example, if we were to say, look, you know what, there are some people who are never going to quit smoking. And so because of that, we're going to make it where we have smoking allowed bathrooms, and we have smoking allowed spaces in airports, and we have smoking allowed spots in high schools, and we have safer cigarettes that have less nicotine in them and have less tar. The real risk of that is that you undermine the messaging that we shouldn't smoke at all. And so it gets all mixed up. And so if you look at what did public health do very effectively and cut smoking rates about in half, is they said, okay, the primary messaging is smoking's dangerous. No one should smoke. We're going to make it socially unacceptable to smoke. We're going to make smoking harder in the public domain. And we're going to increase the cost of cigarettes and reduce access to cigarettes. So we're going to do all these things to squeeze that primary prevention message while still providing every single support we need to people who are smoking and are having health consequences to smoking. So then pulling into the opioid side of things, we want to have interventions. We need to have interventions that meet people in all three spaces, but we need to be really mindful that our tertiary interventions are not undermining the message to young people that, really opioids are dangerous. And they have a place. There is a role for them. We all know there are reasons we take them. But at the end of the day, an opioid, whether it's a prescribed opioid or a street opioid, can very legitimately, realistically cause addiction and can cause lifelong challenges.
And when we're talking about opioids, that tertiary level would be what most would consider a safer supply. Now, with what some agencies are advocating for is what I see to be an unfettered regulated supply, where anybody can, you can go to the liquor store and get yourself a bottle of vodka and some heroin, and that's what I think you're trying to say, right? Is that something like that would tell the masses that it's okay to use heroin, and that would undermine the other two tiers.
Yeah, for sure. Well, we even know that from marijuana legalization, and I'm not arguing against marijuana legalization. The reality, though, is as we look at the data, more and more people are using marijuana now compared to before legalization. And if you look at, sort of what are some of the major factors for a person deciding to use a substance, there are three major factors, primary factors that we have to think about. One is access. If you don't have access to a substance, you're not going to use it. The second is cost. So if a substance is super expensive, you're less likely to use it versus if it's super cheap. And then the third is perception of harm. And so the more we make something seem less risky, the more likely we are to try it. And it makes sense. Like intuitively, we know this, and the research shows that this is true. And so one of the real challenges I think that we face with Safe Supply, which is intended to really help our top tier tertiary folks who have well-established significant illness with opioid addiction, is that even the labeling, like the marketing of Safe Supply, calling it safe or calling it safer, really is problematic, because in places where there is Safe Supply or safer supply, the fact of the matter is that there's more access to opioids, they're cheaper, and there's language that significantly contributes to a perception of less risk. And in fact, over the last 15 years, there's been this shift in youth where they view pharmaceuticals that are prescribed by a doctor that are in pill form that came from a pharmacy as substantially less risky. When the fact of the matter is, I see every day people who started their opioid journey with a prescribed pharmaceutical, and they're now injecting or smoking fentanyl. So, it's a problem.
Yeah. And, hang on a second here. We're going to bring in Donna.
Just on that comment about prescribed opioids, it's been, I don't know, I've heard, and I believe it to be true, that oftentimes when the physician either suspects or the patient admits to having developed an addiction to, then they are cut off. So then they're forced to the streets to kind of make up that difference. Yep. So I'm just kind of curious what your opinion is on that.
Yeah, yeah, and that's a real problem, and it's something that needs to stop. So, I think we should be past, and there's a whole lot of education and change that needs to happen in the physician community. But just because you stop prescribing did not erase the addiction that's there, right? And so, we want and we're working on it. So, for example, in Alberta now, there's a 7 day a week opioid provider line that people can call, where a physician in any practice situation, if they're not sure what to do, they can get expert advice from an addiction specialist. And we would say things like, you know, the addiction is not going to be solved by canceling the medication. You're going to end up with that person in deeper trouble. These are some things that we can do to mitigate the risk, and these are some things that we need to do in order to, help that person stabilize. And it needs to be a healthcare approach as opposed to a, oh my gosh, what's my contribution to this problem? And I feel so horrible and uncomfortable, so I'm just going to push you out the door and try and get rid of you.
Yeah. So we've got a comment in the chat here from Cheryl. Thanks for the comment, Cheryl. And it's in response to, or was it? Oh no, sorry, it wasn't Cheryl. It was Leah. Sorry, Cheryl. I see your comment too. We'll get there. Talking about, black market and restricting. Like, look at alcohol, for example. Look what happened in Prohibition when they criminalized alcohol, and it was pushed underground, and a bunch of really bad stuff happened with, toxic supply and a lot of things that we're seeing now. So going in the full on in the other direction where it's complete, okay, we're going to just eliminate access to this substance is also problematic. Now, we were talking earlier, and you mentioned something about the narcotic transition service that's now going to be available in Alberta that is not going to be unfettered access, but there will be more access in controlled environments to a safer supply. Why don't you tell us a little bit more about that? And why is it that it is going to be very strictly available only in these safe spaces? These safer substances will not be permitted to leave these spaces.
Yeah, appreciate the question. So in Alberta, they recently announced the narcotic transition services, which will be, they're actually two are already running. So in Edmonton and Calgary, they're up and running already. But we've got more coming in North Zone, Central Zone, and South Zone, so into our regional centers as well. And really, they're intended to be a tertiary level response. So for people who are at the top of that pyramid for treatment, who have really severe challenges and have struggled to stabilize on evidence-based medications. And the idea is that in that setting, a person can get stabilized on a non-street supply of opioid, and then gradually, as they stabilize and they're not desperate and having to grind it out, they're all of the medications are provided for them and so on, that then the person gets transitioned over into evidence-based treatment. So whether that's methadone or suboxone or Sublocade or Cadian or a combination, that then we can move them into regular sort of ODP treatment as they stabilize. Although we recognize that there'll be some people who will really struggle to stabilize, and that will at least be a safe place for them. But the Alberta model, different than sort of the BC model, is that the Alberta model really does have that supervised consumption component to it. So the medications don't leave the site. And when I think about it, I have to acknowledge that will be a burden for people. So having to go into a clinic, up to several times a day, even to go and dose, in order to have that safe supply and so on. I think that there's some challenges that come with that, but those challenges are offset by the important need to not cause problems for those tier 1 and tier 2 sort of public health interventions. In that, if we are increasing the availability of street supply pharmaceutical grade opioids, the reality is that those pharmaceutical street opioids are nothing near the potency of fentanyl and carfentanil. And in my opinion, they're less likely to displace fentanyl and carfentanil from established users and are likely to migrate out into inexperienced users or new users. And we may be giving the perception that these medications are safe, and they're not. And so, for example, there is a brilliant article that was published in the Journal of the American Medical Association that looked at teenagers and young adults who'd gone and got their wisdom teeth pulled out. And so they looked at about 15,000 kids who had their wisdom teeth pulled out and then received one single opioid prescription, so oxycodone, oxy or Percocets or whatever. So one prescription, a few days of Percocets, compared to 30,000 kids who got, an anti-inflammatory or Tylenol. And what they found was actually horrific. It was shocking. And so what they found is just from one exposure to an opioid, almost 7%, so 6.9% of the kids who got one single prescription for Percocet, for example, almost 7% were seeking another prescription in the 90 to 365 days after that first prescription, compared to 0.1% of the kids who didn't get an opioid prescription. So that's like almost a 70-fold increase in seeking out a medication from a prescriber. The second thing is that of those kids who received that opioid prescription, 5.8% of them had a healthcare encounter with diagnostic features of opioid use disorder within 1 year, compared to only 0.4% of kids who received the Advil or Tylenol. And so you sit there and you go, I mean, we're talking about one prescription, one exposure to opioid, and it's safe, right? It's pharmaceutical grade, dispensed by a pharmacist, blah, blah, blah.
Safer.
And we're, yeah, exactly. And that's a 14-fold, a 1,400% increase in that kid's risk of having diagnostic features of opioid use disorder within 1 year. That's startling. And, I think that in the medical world, we're not doing enough to inform people of the risks of the medications we're prescribing. We're kind of blindly using medications because we're used to using those medications, where I suspect that there would be some people who'd say, yeah, I'm happy to take that powerful analgesic for my pain, no problem, don't care. But there'll be a whole group of people who say, what? A 1,400% increase in risk of opioid addiction from this one prescription? No thanks, I'll take the Advil. And, I think we need to do a better job there. And then going to the discussion around, safe supply or safer supply, it isn't that we don't want to help people with severe illness. We must help them. And we need to do it in a way that doesn't undermine the rest of the strategy. If we're thinking about people drowning in the lake, yes, we need rescue boats. Yes, we need to have lifeguards and people out there rescuing as many people as we can. But if we know that place is dangerous, we also need to get people to stop swimming in the water there.
Yeah. So let's take a quick break here and hear a word from tonight's sponsors.
Now that I've left Prairie Sky, I just feel free from my addiction. Treatment saved my life. Prairie Sky Recovery saved my life.
So before we move on, I just want to throw something at you here. And I know that I have friends in the community here who believe this, so I'm just going to chuck it at you. When we talk about a safer supply being available only in a certain place and very strictly monitored, and it's not allowed to leave that place, some would argue that if that safer supply that is regulated and people know what's in it, if that were to leak out into the community and someone in the community were to use that instead of something that is from the illicit supply and possibly skirt an overdose or a drug poisoning, is that not reducing the harms in the community? Like, why you got to be tight with the safer supply? You know what I mean?
Yeah, Yeah, I love the question. So, and it's a challenging question for sure.
Hmm.
I think we could use maybe corrections as a good example of this. So, we know that in the correction setting, when we use medications like suboxone, that that's a real benefit for people who have opioid use disorder, and stabilizing them, allowing them to sort of make decisions without the compulsion of their cravings and their withdrawal, and a huge benefit, and I'm a believer in it. And there is medication that gets diverted into to other members of that population, and what you see is that there's a reduction overall in overdoses in those settings, and so you can reduce the overdoses. The flip side, though, is that we also see, and I see this in my clinical practice, people who come out of corrections where maybe they went into corrections and they were using methamphetamine before and they were methamphetamine addicted. And now they've come out of corrections and they've tried to come off of Suboxone that they were using illicitly, snorting or whatever. And now they're also addicted to opioids. And so now they're a mixed opioid user. And if they stay on Suboxone, we can do some things to help them, wean off in complete treatment if that's their goal. But at the same time, we've now added a problem for them. And that's a real phenomenon. So we have to balance those risks out. And there, at this point, I'm not aware of a single strategy that's going to work for every aspect of this. The flip side, though, is that Purdue Pharma and the oxycodone fiasco contributed to us having a lot of people exposed to opioids, 20 years ago and 15 years ago. And we're still cleaning up the mess of overprescription, overprescribing of opioids. And the last thing I think we want is a new wave, a new generation of opioids, because we've made decisions that undermine the sort of fundamentals of prevention.
So when we're talking about the VOPD here, what is the biggest demographic? Excuse me. What is the biggest demographic that is consuming this service?
Yeah, so we serve people from teenagers right through to people who are over safe. One of the really great things is that we actually, in Alberta, I don't know if this is the same in Saskatchewan, but 3 out of every 4 overdoses in Alberta are men, and it's hard to reach men who are using. But with VODP, what we see is that the people who are accessing our services are predominantly in that working age group, and somewhat more men than women. So about just under 60% of the clients we serve are men, about just over 40% are women, and so we're happy about that. We'd love to reach more people, and in fact, we want to reach everybody who needs the service, and make sure that they get care. But we're really reassured. So if you look at our statistics in Alberta about who's overdosing and you overlap that with who our program's serving, they match up pretty good.
So when we're talking about, and sorry, I'm sort of bouncing all over the place here. I apologize, but there's something that I forgot to ask you. And when we're talking about the narcotics transition service here, like, give us an example of who you would prescribe a safer supply to, as opposed to just like offering them methadone or Suboxone. Like, why with the methadone and Suboxone that's available, it's safe, it's stable. Why would safer supply need to come into this equation?
Yeah. So appreciate the question. It's interesting because I think that, broadly speaking, we want to make our safest, best evidence-based choices the easiest choices to receive. And so, one of the things that's been decided in Alberta with NTS, with narcotic transitions, is that narcotics transitions cannot be offered in locations that don't have ODP. So,
What's ODP?
If a person, opioid dependency treatment, sorry.
Okay.
So, methadone, Suboxone, Cadian. And so basically, we don't want to make it easier to get heroin than it is to get methadone or Suboxone. And so the services need to be co-located. They also need to have similar hours. So NTS needs to have, wide hours of operation, 7 days a week, 365 days a year, in order to meet the needs of the people who are using that service. Therefore, ODP needs to have those hours as well, which is great for people. It's far too long has it been that you can, check in with your methadone team Monday to Friday from 8:30 in the morning till 4:30 in the afternoon. So expanding those hours into the evening and weekend is important. But if we've got somebody who maybe has struggled on methadone with actually, get in control of their use or stabilizing, if we've got somebody who's really struggled to get on suboxone and stay there, and they're not sure whether or not they're able to stabilize, or they've had overdoses and they're worried for their safety. This is a person that I think we would consider for NTS, and with the goal being really to use these high grade opioids that frankly are not evidence based, but will allow that person to have a safer supply that's used in a supervised setting and isn't street. That as that person now also no longer needs to grind it out because there's no cost to the service, that then they can start making some decisions for themselves about where they want to go next with their care, including transitions, and that's part of why it's called a narcotic transition service, including transition into the evidence-based medications and stabilization, and then moving forward in the direction that that person wants to go.
So there's certainly expectations attached to the narcotic transition service. It's not like, here's a safer supply, stay alive, have a nice day.
Yeah, I think that there's expectations on the providers. That's how I would put it, is that if I'm a provider working in that setting, I have an obligation to be reassessing the situation, to be working with that person, understand what their goals and motivations are, and then to work stages of the change and to help that person sort of achieve those goals that they have, instead of sort of just going through the motions. And this person has been on this same medication forever and is still overdosing because they're still using in the community, and et cetera, that we need to be a little bit more mindful and a little bit more active in our assessment and treatment, and sort of intention around treatment.
I at that CSAM conference that where we met, and for anyone who doesn't know, CSAM is the Canadian Society of Addictions Medicine. They had a conference here in Saskatoon this year. It was wonderful. A man by the name of Benjamin Perrin did a talk, and one of the slides he showed during his talk was a person holding a sign, and it said, "Every death is a policy failure." Now, do you believe that? And in the context of substance use and the harms that are associated with it, do you believe that every death as a result of substance use harms is a policy failure?
Yeah, I've seen those pictures and those slides, and they make it into the press. My straight out answer is no, I don't. Mm-hmm. I think that there are lots of things that we can be doing from a policy point of view to help. And so, for example, in Alberta, it really used to be that if you lived in rural Alberta, you were screwed. If you had a substance use disorder and you lived in a small town, unless you were going to relocate to the city and give everything up, you could not get access to care in a reasonable way. You'd have to sell your house. If you had a house, you'd have to quit your job. It just sort of insane barriers. So in some respects, there are policy things that must be changed in order to help people. But the fact of the matter is, and I think, one of your previous guests was talking about sort of Al-Anon and 12-step and recovery for family members and that sort of thing, that we have to give up the idea that we actually are in control of other people. So no matter what policies we put in place, no matter how perfect of a system we build, and certainly I'm not saying our system is perfect, there's lots of work to do. But no matter what we do, the fact of the matter is that I am not in control of other people. And if a person chooses to use substances in a way that's very high risk and it results in their death, as tragic as that is, the fact of the matter is that the system isn't designed to control any one person's behavior. So on the one hand, yeah, there are policies we need to fix. On the other hand, it's in a way, it's like the spouse trying to control the person who's drinking by hiding the bottles and controlling the money. The
Yeah,
fact
yeah.
of the matter is we can become so sick in our attempt to coerce and manipulate and change another person's behavior that it actually prevents us from being useful.
Mm. So what's next? Surely we haven't cured addiction, and we're not sailing off into any sunsets anytime soon. What do you see next after all that you've achieved? Certainly, there's a next step.
Yeah, well, there's lots of areas where we need to keep working. So, in terms of opioid dependency treatment, one of the active areas of work in our team is actually looking at helping people who want to complete treatment and come off of their treatment medications do that in a safe and effective way. So there's some work there because the evidence around that is challenged. So if you look at it, there's a significant increase in overdose risk in the month after discontinuation of medications. That being said, that evidence also includes people who stop their medication because they relapse. So how do you tease out what's sort of a person who's working their recovery and well compared to somebody who's relapsed? And so there's some exciting things there that we're working on. The government of Alberta just announced recently that we've secured some funding to develop a new children's team. And so this is for children and youth who are suffering with serious addiction and who are just extremely vulnerable. And what we've seen in practice is that many of these kids are in locations where there are in-person ODPs, but the in-person ODPs are opioid dependency treatment programs. Sorry, I keep using acronyms.
No, it's okay. Now that
But
we know what it is, it's okay.
yeah. So there are so many of them where the program's designed for adults, and so you have this kid sitting in a waiting room with a bunch of adults, maybe even adults who have been part of their previous victimization, to be frank, and as well, expectations of the in-person ODPs of a person, needing to be at an appointment during working hours when they otherwise have school or other things that are going on. And then they end up getting cut off of treatment too, just like the adults do. So we've said, look, there's an opportunity to use virtual tools to do this in a better way, to be low barrier, to follow the evidence, and also, monitor what we're doing and create the evidence to support care for kids who need it. So we're really excited about that. And then we've also started working more closely with our provincial correction system. So trying to figure out that right balance between making sure that everybody who needs to get treatment gets treatment and gets it in a timely way. It's not okay for people to just languish and suffer because the system's not designed for them. So we're working there as well.
And we're an impulsive bunch. Like when I was reaching out for help, like I'm like, I need help. And that means I need it right now because in 5 minutes, I'm going to be back off in the sticks again. So timely treatment and whatever services that are becoming available is critical, really.
Oh, absolutely. Oh, and I jump in and say that was one of the major benefits that we saw with our same day start service is that you'd get a request for service on Friday. And if you booked that person for telehealth on Monday, they'd no show because you weren't able to help them in time. Whereas if we just help them today, well, they show up today because they're here today. And
they need the help
it's
today.
amazing. Yeah. And it's so dumb in its simplicity, like it shouldn't have taken this long for us to figure that out.
Yeah. People need help when they need it.
Yeah. Yeah, exactly.
I need some sound effects in here. I need like a little bell or something, like bing, confetti.
I have chest pain, so come back next week.
Yeah, we'll have a look. Or call back, and if you want to get into detox, you have to call back every day for a number of weeks. That's like saying, like, oh, you've got a broken leg. Well, why don't you run around the block twice and then walk through the doors, and we'll put a cast on it. So we've got John chiming in here with a comment. John Roosh, thanks for the comment. John says, safe supply makes sense. If they are not going to stop, at least it reduces overdoses. It has been proven in town here. I'm on the fence with it, but it seems to what does it say? But it has worked. What do you think? Do you think there's truth to that? Like, do you think that it would be all bad if a safe regulated supply became available?
Well, what I'll say is that the evidence that's being published in Canada, if you read the articles, they deliberately disclaimer on all of them that they're not measuring for community outcomes. So if I'm going in, if I'm a person who is opioid dependent and I've struggled on methadone, suboxone, and I'm going for safe supply, and I'm typically using fentanyl or carfentanil, you can give me 100 tablets of Dilaudid, and that Dilaudid's not going to be super helpful for me from a tolerance point of view. And so if I turn around and I sell those 100 tablets for $50, and now I don't have to grind it out, I don't have to, commit crime, or I don't have to prostitute myself or whatever. I should take that back. I don't have to trade in order to take care of myself. Like that is a huge personal benefit for me. I'm also engaged with staff, and I'm engaged with other services that are going to be a benefit for me. So I think that there likely is a real benefit for the person who is right there using the service. The flip side, though, is that the studies do not measure for community outcomes. And so if in that tertiary intervention, we provide a real meaningful service for that person, but we cause 50 people to enter opioid addiction, we might end up with 10 new people who end up in that severe tier, or 5 more people in that severe tier. And so we're creating more problem.
But that's speculative at this point. So all of the articles that you just mentioned said that these do not measure community outcomes. So when you're saying that these tertiary measures may overshadow or overarch our primary and secondary measures, that's speculative. We don't really know for sure if that's right.
I don't think it's speculative. I disagree with you on that. I think that we know from long experience that increasing the amount of opioids prescribed into a community increases the amount of opioid addiction we see in that community. And we saw that through the OxyContin crisis. But on top of that, I hear quite regularly from physicians in communities where there are safe supply programs, where they're seeing youths who are using safe supply medications that are diverted and are now addicted to those medications. And we routinely, like I was saying before, we routinely see people who started on prescribed medications and are now using fentanyl. And so it isn't speculative to say that a person who's using sort of safe prescribed medications has a very high risk of turning into someone who now is needing to use extremely high potency medications in order to feel well.
Okay. I think that's
all. And to be frank, there's a reason why those things are not being measured.
Oh, why is that?
Well, because there is very legitimate risk for diversion. In fact, there was a paper recently released by sort of the Association of Practitioners who are involved in safe supply that is really looking at, so the purpose of their paper was normalizing diversion and, saying, look, diversion is compassionate. Diversion is reducing risk for other people's diversion is that group. And I'm not trying to say that the people who are providing safe supply and are working in that space are, deliberately trying to cause problems for our population. I think that they're working very hard to meet the needs of those tertiary patients, but they know that diversion's a real thing, and it's a real problem, and it's easier to not measure it than it is to measure it and say, hey, there are pros and there are cons. It's much easier to say there are just pros.
Yeah, of course.
In a way, it might be more straightforward to say, hey, look, rather than give safe supply of medication, and again, I really cringe at calling it safe because we have to be so clear about our language. Language matters. It might be more effective, who knows, to give people who will engage with healthcare $50 a day.
Fair enough. In fact, I was going to go there, but you just did. So there you go. Okay, well, that's all I have for you. Donna, is there anything you'd like to add?
Well, I'm sorry, my voice is cracking here, but I'm just kind of curious about, sorry, cold brain, my brain, In terms of the like toxic supply on the streets, some would argue that even that diversion is basically a form of harm reduction against anybody having to access that toxic supply, and especially, the kids and people have trying to have a good time on a weekend that aren't necessarily your typical addict per se.
Yeah, I get that, and if safe supply would just displace the illicit supply, I think that there's a rational argument to be made there. But the reality is, it doesn't displace the illicit supply; it just adds to the illicit supply. And so we know that even with marijuana. I was actually just recently chatting with a community member who was talking about how in their community they had two kids recently die of overdose who were smoking marijuana, apparently that had fentanyl in it. And you go, that, like, what a tragedy. So two young kids die of an overdose using marijuana, but we have a safe supply of marijuana. And legalization of marijuana and a safe supply of marijuana has not displaced the illicit supply of marijuana. And the reality is that the drug dealers who are selling, the cartels that are making fentanyl and shipping it to Canada, they're not just going to, roll over and fold up shop and leave the hundreds of millions of dollars that they make selling fentanyl here just because we legalize something. And in fact, when you think about access, cost, perception of harm, the fact of the matter is that we could end up convincing more people to try opioids because some might be safer than others, versus a public health message that says opioids are really challenging. Like, think about that dental study. Just one-time use of opioids increases your risk of opioid addiction by 1,400%. So if you're gonna mess around with a drug, maybe try something else, right? Like, opioids are not a good way to go.
Yeah.
But I think the major problem is by and large everything that's available on the street is tainted or dirty. So I'm kind of curious if you have any insight how we might tackle that particular problem.
Yeah, well, I think that that's where some of our sort of core harm reduction strategies actually really have a place. So I think that it's important that people who are using or choosing to use drugs, that they have a naloxone kit handy, that people don't use alone, that in Alberta, they've developed something called the DOORS app, which is the digital overdose response app, which basically, if you're going to use something and you don't know what you've got, you can fire up that app. And if you go unresponsive, it's going to activate EMS and it's going to summon them to that location where you were at. EMS is going to be getting that sort of high level code they need to get there right away, as soon as you basically go unresponsive. So, we're not going to be able to solve all of the different challenges that we have, but there are some things that we can do to mitigate the harms that come. I think even if we went, and I know that there are some in the activist community who are providing sort of pure, only caffeine as the adulterant, cocaine and methamphetamine and that sort of thing. And the reality is that I think marijuana teaches us that the illicit market isn't going to give up. And, they'll provide better service. They'll deliver it to your door and they'll be there in the middle of the night, and they'll beat the government supply on cost, and people will still overdose.
So also what you're kind of saying is, and I mean, I believe the evidence supports this idea that the just don't do drugs and hugs are better than drugs approach doesn't work. However, is it, I think what you just said is it's better to teach kids about these sorts of apps and how to use naloxone and Narcan. But is that actually being implemented within the education system?
Well, I think that there's a huge amount of work to be done in the education system still. So that's, an active area that needs, additional work. I think that it's important for us to recognize that the sort of hugs not drugs and don't do drugs thing actually does work for some people. And so it doesn't work for everybody, but it does work for some people. And so that education piece where we're saying, hey, look, these substances can be very dangerous, and actually, let's maybe start dealing with people's trauma and helping people to become comfortable in their own skin. And some of these like core prevention strategies that we need to do those, and we need to recognize that we of course still need our second tier, third tier approaches to help the folks that approach doesn't help. So it's like getting the population to not smoke cigarettes. We still have lots of people who smoke cigarettes, but there's actually about half as many who used to smoke cigarettes. So the prevention message actually worked for half of people who would have ended up smokers previously.
I'm
And
gonna be
so, you know,
I'm gonna be kind of like a jerk here, I guess you could say. But so
Donna
people,
coming in hot.
sorry,
Here we go.
people are not smoking per se, but now we're vaping. Because like even I switched to vaping, and part of that was peer pressure about the whole the social unacceptableness it is to be a smoker. So now I vape, and now it's okay.
yeah, yeah, and I think vaping is a great example
I never
of
said it was
undermining
okay.
primary.
If we're looking at people
Excuse me?
that said it that said it was okay, I didn't say it was okay. I did say it was better. I did say that. So sorry,
Yeah, well,
Nathaniel.
and to be honest, there is some suggestion that it might be better. The jury's still out, but I think that's a really good example, actually, of how we can undermine that primary prevention message. So we actually saw significant reductions in smoking uptake in youth, and then vaping came around after the fact, and it's caused a rise if you add smoking plus vaping together, and kids who vape are significantly more likely to end up smoking. And you say, well, gosh, the industry behind vaping, well, they've done some of the exact same things the tobacco industry did, back in the day. So having appealing flavors, having certain marketing that's appealing to children, all that stuff, where tobacco can't do that. Tobacco can't advertise. Tobacco can't, put their labels up in front of kids and all that. And there's an argument to say, hey, look, we maybe need to hold the vape manufacturers to task around some of the strategies they've used to increase penetration of their market. But that then you get into sort of, are we trying to prevent everything, or are we trying to reduce harm? Are we trying, some people are going to use no matter what we say and do, and how do you balance all of those tiers out? My main point, though, and I hope it isn't lost on any in the audience, it isn't that I'm against tier 3 interventions. I'm not against safe supply. I'm not against sort of these interventions to reduce harm for most severely affected. But I would really love it if one day we had less people struggling with opioid use than we do now. It would be nice if people who are swimming in the river had life jackets like the Doors app, and that we weren't pulling them out from deep, and we weren't pulling out their bodies from fatal overdoses. And it would be nice if people were able to get comfortable in their own skin. So, if we could start working on the childhood trauma and the very substantial challenges that people face, that, unfortunately, sometimes we contribute to, that we could have a healthier, happier population.
Yeah. So we got one more question for you. Cheryl asked some time ago, and naloxone did come up. So now's a good time. Cheryl asks, why isn't the government giving out nasal Narcan kits, which are 4 times more effective than syringes?
So I can't answer that question. I don't know sort of what the policy decisions are around nasal versus injectable naloxone. I do know that in Alberta, in Edmonton and Calgary, there are nasal naloxone projects that are ongoing right now, and I think that the evidence around nasal naloxone versus injected naloxone is something that's actively being evaluated.
I'm just trying to... Hang on. Ta-da! I've got one right here. I don't know what significance that is, but I do have one, and I got it for free. So there's that. It's not impossible to get, but I'm also not in Alberta, so who knows? But
yeah. No, I know that there are some projects aiming to see whether or not it increases use, decreases overdoses. So there's some active work in that area. One of the things that I am aware of around nasal naloxone is that it's significantly more expensive than the injectable.
Okay, Nathaniel, we have grilled you enough for one evening, I think. Thank you for being so forthcoming with us. Thank you for, I know we came in hot a couple times there, so glad you, Donna's over here chuckling away.
I'm sorry.
She's not sorry. Don't buy
No,
her
don't.
that.
Yeah, and don't be anyway. I
Yeah.
like the tough questions because
Yeah,
that's
this
where
is-
we get interesting.
This isn't soft Knox talks. This is hard Knox talks. So, and with that, we will let you go, my friend. Thank you so much for spending some time with us this evening, and take care, man. We'll see you again. All right, if you're getting something out of what we're doing here, you can find us on all audio platforms like Apple Podcasts, Spotify, Google Podcasts, or wherever you listen to podcasts, or live and interactive right here on Facebook, YouTube, or Twitch TV. Thanks for watching, everybody. Take care. We'll see you next time.